From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to this JAMA Cardiology Author Interview podcast. My name is Sadiya Khan. I'm the Magistrat Professor of Cardiovascular Epidemiology and Associate Professor at Northwestern University and an Associate Editor at JAMA Cardiology. We're going to be discussing a really interesting paper today looking at postpartum ambulatory blood pressure patterns following new-onset hypertensive disorders of pregnancy. And I'm joined today by Dr. Alisse Hauspurg, who's an assistant professor at Magee Women's Hospital. Alisse, thank you so much for joining us.
Yeah, thank you, Sadiya, for having me. It's really exciting.
Well, there's several innovative features about your paper, but perhaps first let's take a step back and talk a little bit about the scope of the problem. Can you tell us a little bit about what motivated you to study postpartum blood pressure monitoring?
Sure. So hypertensive disorders of pregnancy are very common. So we know that they complicate up to 20% of pregnancies in this country. And a lot of attention and focus has been on management and intervention development to either prevent the development of hypertensive disorders of pregnancy or has been focused on how we actually manage people during pregnancy. But there's really a very big gap in the evidence and in guidelines in terms of management of people in the postpartum period. And we know that that's actually the time when individuals are most likely to have morbidity related to hypertension, which is what got us interested in actually studying this in more detail.
Yeah, it's a really important point when we think about the impact of elevated blood pressure. A lot of times it's silent, but particularly in the postpartum period, it can lead to hospitalization, which means disruption for families, time away from the child, but even more serious things like heart failure, heart attack, stroke. And these are key drivers of maternal mortality.
Yeah, exactly. And for a long time, essentially what was happening in the postpartum period, what was happening with blood pressure was really very much a black box because we were relying on postpartum individuals coming into in-office visits to actually get data about what blood pressure is doing. Prior studies have shown, kind of in a smaller capacity, that there is an exacerbation of hypertension that happens after delivery, where people will actually get spikes in blood pressure in the first couple of days after the delivery. And most of the time that's happening after they leave the hospital. And as you said, it often can be asymptomatic, which is what from an obstetric standpoint can be very scary to us because it can lead to a lot of complications that happen at home. And often the focus in the postpartum period, right, is on care of the newborn and not necessarily maternal care or maternal health.
So you designed a really interesting study to be able to leverage real-world advances in technology for remote monitoring and then applied it in your health system. Can you tell us a little bit about the methods and how you identified your study population?
Yeah, sure. So we developed a postpartum remote blood pressure monitoring and management program at our institution. And essentially what we've done is for any individual that either has a diagnosis of a hypertensive disorder of pregnancy or has elevated blood pressures in the postpartum period, we enroll them into a home blood pressure management program. It's text-based, so the individuals are given a blood pressure cuff at the time of discharge from the postpartum hospitalization. That cuff is validated by a bedside nurse, and they're educated on how to actually measure blood pressure correctly, what values are going to be of concern. And then after discharge, for the first 2 weeks, they're texted daily to ask to report blood pressure and also ask about any concerning signs or symptoms. And then all of that program is monitored by a centralized team of nurses. And within our program, everything feeds back into the electronic medical record, which allows for individuals, providers, whether it be a midwife, a physician, to be able to actually see what their blood pressures are doing in the postpartum period. In terms of the management, that's all done. We have a centralized team of maternal fetal medicine physicians who manage all of the blood pressures through our system through this program. So if we're noticing that people are sending in elevated blood pressures, if they're having symptoms, we have algorithms that we follow to be able to initiate medication through the program.
So walk us through your key results. You found some interesting patterns. There's actually a lot of differences that happen in blood pressure as you're monitoring during this time period.
Yeah, so we had a couple of key questions that we were really interested in. And as I kind of alluded to earlier, because there has not been so much focus on what's happening in the postpartum period, there's really a pretty significant lack of data of what these patterns look like after delivery. So we were particularly interested in looking at the prevalence of ongoing hypertension after hospital discharge, as well as the prevalence of severe hypertension. And we know that severe hypertension, particularly in pregnancy and postpartum, is associated with a significantly increased risk of maternal morbidity, things like seizures, strokes, heart failure. And what we found is that in our population, which again was being monitored through this very robust remote monitoring program, there was still a very high prevalence of ongoing hypertension after hospital discharge. So over 80% of individuals had elevated blood pressures defined as 140/90 after leaving the hospital, and 14% of our population actually developed severe hypertension after discharge.
One of the things that surprised me was how many people needed to come back for an emergency room visit and readmission. How generalizable are these rates compared to the US population? Did this seem high to you or where you would expect it to be?
Hypertensive disorders of pregnancy are the most common reason that individuals are readmitted to the hospital in the postpartum period, and one of the most common reasons for emergency room visits, which is part of why these were two of the outcomes that we were particularly interested in looking at. And we found, not surprisingly, that those who had ongoing hypertension, and in particular, those individuals who had severe hypertension, had the highest odds of emergency room visits and postpartum hospital readmissions. So, in terms of thinking about where these rates are compared to other institutions, I would say we fall sort of right in the middle in terms of the readmission rates being around 5%. And depending on kind of the population characteristics, that there can be a wide range of postpartum readmissions. Because our institution is a referral hospital and we tend to care for people who have higher acuity of hypertensive disorders or other medical issues during pregnancy, those rates may be slightly higher than institutions that care for sort of a lower risk population.
Yeah, particularly in your severe hypertension group, about 16% came back to the ER and 13% were admitted. And so it's more than 1 in 10 people who have elevated blood pressures that are being admitted. So what can we do about this?
It's a great question. And I think whenever we're starting to think about like how can we actually improve outcomes and reduce complications for this population, I think the first step obviously is having this data to say like this is a big problem that is driving these readmissions and emergency room visits. And I think our data suggests like when we actually look at postpartum blood pressure patterns after people leave the hospital, our data suggests that we probably should be doing a better job controlling blood pressure even prior to hospital discharge. And I think it's important to take these results within the context of the fact that this is within a remote management program where we're actually starting medications, we're trying to do things to keep people out of the hospital. And so these data may actually look worse if we were to look in a population that doesn't have a program to actually be starting medication outpatient and to be monitoring people after hospital discharge.
So you touched on a really key thing, which is monitoring blood pressure in and of itself is probably not the solution, but a first step. If we don't know where elevated blood pressures are happening, we're not going to be able to act on it. But we also have some evidence gaps in how to best manage once we identify elevated blood pressure. Is that fair?
That is exactly correct, Sadiya. Yeah, I mean, I think when we look at some of the guidelines around this, there's not a lot of data and therefore not a lot in the way of guidelines on management and blood pressure goals in the postpartum period. And because of that lack of evidence and lack of guidance from ACOG, from the American College of Obstetricians and Gynecologists, and from the Society for Maternal Fetal Medicine, it's led to major variation in practice. And I think what our data suggests when we look at inpatient blood pressure values and how that translates to postpartum blood pressure patterns after people leave the hospital, what we find is that it probably would be reasonable to start thinking about initiation of medication at a lower blood pressure.
I think you've outlined really an important clinical trial that perhaps needs to be done that comes on the heels of CHAP. Do you want to tell us a little bit about how CHAP has maybe helped us understand where blood pressure targets should be in pregnancy for chronic hypertension? And here we're dealing with new-onset hypertensive disorders where there continues to be a gap.
Yeah, sure. So the CHAP trial was a trial that randomized individuals with mild chronic hypertension to a lower blood pressure target. So essentially maintaining at less than 140/90, which really is what the goal blood pressure is for most of the population in the US. And they compared that lower blood pressure threshold to what we've sort of traditionally used in pregnancy as our threshold, which has been 150/100. And what they showed is that actually there was lower rates of preeclampsia and less maternal morbidity, less maternal severe hypertension in the group that had tighter blood pressure control. One of the concerns in obstetrics with managing blood pressure tighter during pregnancy has been concerns about fetal growth and neonatal outcomes. And CHAP really showed us that managing blood pressure a little bit tighter during pregnancy really does not increase the risk of fetal growth restriction or adverse neonatal outcomes. And I think CHAP has really given us, at least in obstetrics, has been very much practice changing, that for those people who have chronic hypertension coming into pregnancy, we're managing blood pressure much tighter during pregnancy. And actually that is translating to tighter blood pressure control in the postpartum period. But again, because our population was focused on those with new onset hypertension during pregnancy, so preeclampsia or gestational hypertension, there is still a big gap about how we should be managing those individuals both during pregnancy and in the postpartum period.
So if we take a step back and think more broadly about the implications of your work, I think one of the other really important aspects is that you had a very diverse study population and you were able to include people from a variety of racial and ethnic backgrounds and socioeconomic backgrounds. When we think about the burden of hypertensive disorders of pregnancy and the inequities that exist in terms of the development of hypertensive disorders as well as the complications following that, how do we best implement something like this on a broader scale?
You bring up a really important point. We know that individuals who self-identify as Black are at increased risk of complications related to hypertensive disorders of pregnancy. And much of that is driven by systemic racism and all of the other barriers to care that exist within our healthcare infrastructure. We also know that there are major issues for rural populations, for populations that live in maternity care deserts who may not have access to obstetric care, within a reasonable distance of travel. And so I think one of the ways that we can think about how to address these inequities is by implementing these types of programs, so self-monitored blood pressure programs and remote management programs more broadly. But I think there's a lot of barriers to implementation of these types of programs in the postpartum period. One of the biggest one is access to validated devices. We know that the infrastructure of these types of programs can be very expensive. And so thinking about who's actually paying for them, how they're being reimbursed, is going to be critical in terms of being able to more broadly impact our US population.
So I think, Alisse, you touched on really multiple levels of barriers. There's the individual level barriers, including barriers to blood pressure cuffs and or monitoring. There's health system level barriers in terms of programs like this that need to be scaled. And then there's policy level barriers, particularly related to health insurance access. And Medicaid extension is one approach to helping with this. And your study looked at the first 14 days, but how much more of the blood pressure challenge do we see that might come with time if we were looking out to a year? And what are other strategies that we need in place to perhaps really be able to monitor both new onset postpartum hypertension as well as continued monitoring for those who have already had elevated blood pressures in pregnancy?
Yeah, thanks, Sadiya. I think Medicaid extension truly is actually just the tip of the iceberg. I mean, that should really be the bare minimum. And I think depending on when this gets aired, I think we're at 47 states now that have passed Medicaid extension to a year postpartum. And, you're exactly right. We only, within this study, talked about the first 14 days postpartum, as we know that this is the time when there tends to be this labile blood pressure and this increased risk of maternal morbidity. But we know long term that these individuals with new onset hypertensive disorders of pregnancy have an increased risk of ongoing hypertension and an increased risk of cardiovascular disease across the life course. When we look at our data, we see that over 50% of people who had no hypertension prior to pregnancy are still hypertensive at 6 weeks postpartum, which is sort of the traditional time when Medicaid coverage has ended. And so I think that is for sure at least the first step, is being able to extend care through a year postpartum so that we can continue ongoing management of this hypertension and ensure that individuals have access to other preventative screening to reduce overall lifetime risk.
Yeah, I think you really are just starting to uncover the full burden, because new onset hypertensive disorders of pregnancy are one group, but people with chronic hypertension, those with new onset postpartum hypertension. So clearly a lot of work to do in this monitoring space. Is there anything that we haven't touched on that you think is important to highlight or amplify in terms of the implications of the study?
In terms of a final takeaway, we think that these data really support the critical role of remote management programs for blood pressure in the postpartum period and highlight the need for improved tools for risk stratification. Thinking about how we can make this type of infrastructure accessible to more individuals across the country, we think will have a significant impact on improving maternal morbidity related to hypertension after delivery.
I think that's really well said, and perhaps we'll end with this call to action for the importance of patient education and advocacy around blood pressure levels being monitored, around healthcare providers and systems being able to implement monitoring programs, and really policymakers to prioritize blood pressure monitoring and hypertension as a critical driver of maternal morbidity and mortality. Thank you so much, Alisse, for joining us.
Yeah, thank you so much for having me, Sadiya. This was wonderful. I really appreciate the opportunity to highlight our work.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.